go up sometimes up to 40% in heart failure patients, severe heart failure on spironolactone 50. Just I want to mention in this regard that it's written in textbooks that spironolactone 25 and 50 or 75 or 100 hasn't got much of a difference so far its action is concerned against heart failure or other features. So if we are at 25, we are at par. We don't have to increase it to 100 because 100 or 50, the chances of hyperkalemia will increasing linearly. Now, up to 25% of the patients are dialysis patients, you know better than me. 17% patients are diabetic over a 3-year period, and resistant hypertension with add-on MRA therapy is also there because we know that spironolactone works well. Now, of course, there are two such molecules, losunratrat, which is not available in our country, was presented on 28 in ACC and by a lady, and also another bactrostat which is also not available till now in our market, will be hitting the market. I don't know how effective they are. And up to 8 to 17% of patients are from resistant hypertensive patients where we give, telmisart and so on and so forth along with spironolactone, maybe 25 to 50 milligrams. And in the general population also we find some incidence of hyperkalemia is very small, and this is the more than 10% of Indians are suffering with hyperkalemia. So this is a global picture, and you can see that in China is 5 to 10%, and if you look at the map in the South Asian countries who are sticky rice eaters, I don't know why, but you see Hong Kong less than 5%, Indonesia less than 5%, Japan 5 to 10%, Malaysia also same, Philippines less than 5, Singapore less than 5, South Korea, Taiwan again less than 5. So in the sticky rice area or fish eating area or seafood consuming area, the potassium is little on the lower side. In our country it's around 10%, in Latin America it is 13.4, in US it's 5%. They are more health conscious. In Europe also, in US it's 5%, in Europe it's 5.9 or 6%. Hyperkalemia associated risk of hospitalization increased in cardiorenal patients. As I told you, 5 milligrams of enalapril, and at 2 o'clock in the midnight we had to put a wire. The 6-month hospitalization risk after index date was 3.8 times higher. The hazard ratio was 3.78 with a confidence interval of 95% in patients with CKD and hyperkalemia. In patients with heart failure and hyperkalemia, it's same 3 times more than the control population compared to matched patients with CKD or heart failure without hyperkalemia. This is the projections. Cardiorenal patients reported hyperkalemia recurrences also at successfully shorter time intervals. We know about it. Percentage of patients with hyperkalemia recurrence increased in those with prior recurrence in the 6-month follow-up post-therapy. Patients with CKD stage 3 and 4, hyperkalemia, these are the figures you can see, and you see the recurrences when it occurs, they come earlier. First you see with CKD patient 45 days, then it is 35, ultimately 27 days, though the numbers were not very large. And patients with heart failure who had CKD and stage 3 to 4 and hyperkalemia, you see the interval is coming down from 42 days to 26 days, the time of recurrence. And average time between hyperkalemia recurrence decreased with each additional episode. Let us deep dive into the available treatment options. What are they? So we know that we give calcium gluconate, but it doesn't reduce. None of them reduces the potassium. It's a membrane stabilizer. Onset of action is very quick, within 1 to 3 minutes, and therefore we give it immediately after diagnosing in ABG that there is hyperkalemia. Efficacy can be monitored with ECG, and dose can be repeated if no changes observed. Short duration of effect, 30 to 60 minutes. Serum potassium level is unaffected, as we told. Avoid in patients receiving digoxin because of risk of digoxin toxicity and risk of hypercalcemia is there. Now coming to the insulin glucose, potassium redistribution into the intracellular space, that's the mechanism of action. Onset of action within 30 minutes, again very quickly, effect lasts 4 to 6 hours and risk of hypoglycemia is always there. And it does not reduce the total potassium levels. Dialysis, we know that's the ultimate to remove when the potassium is 7. We resort to dialysis and we reduce it with early onset of hemodialysis. And effects of lasting until end of dialysis or longer. Concentration of potassium in the dialysis also can contribute to the hyperkalemia. And emergency management strategies don't eliminate total potassium levels. That we should remember. They cause redistribution of potassium into the intracellular space. Now, these are the few options so that long term we can manage the hyperkalemia, low potassium diet, like not taking lot of fruits or dal, reduction in potassium intake may improve metabolic acidosis in CKD, limitations difficult to adhere to. Who likes fruit, he can't be without fruits. Who likes dal, he can't be without dal. Limiting potassium rich foods can cause constipation and contradicts DASH diet and may worsen chronic hypertension. Discontinuation or dose reduction of RASI therapy. Now, it is equally criminal on our part. We can't take out the, this RASI therapy, just stop it. But as I was compelled to stop in this patient with 8.2 creatinine, I can't continue. Of course, I have given Localma to this patient also after the potassium and creatinine has come down. Let us see how he does. Recently, we have added this molecule to other patients, and we have found that the molecule acts very, very quickly. And this prevents recurrent of hyperkalemia events by discontinuation, but that's not coveted. Stopping or suboptimal utilization of renal or cardioprotective RASI therapy. And I'll show in a slide that it is equally harmful like reducing the dose of RASI therapy. Traditional potassium binders like sodium polystyrene sulfonate we often use. Potassium elimination, onset of action is very quick, 2 hours. Effects may last 4 to 6 hours or longer, but there are some difficulties. There may be intestinal problems, serious GI adverse events reported, including fatal cases of intestinal necrosis, caution with sodium loads in patients with congestive heart failure. That's of course a concern with this molecule, sodium zirconium cyclosilicate. I will show you that study also. And hypertension or edema. Appropriate for immediate subacute care only. RASI down titrate, discontinuation are having serious consequence or cardiorenal patients. Down titration or discontinuation of RASI, you can see, is common following hyperkalemia event. This is the retrospective analysis in US with 2 lakhs patients or more. You can see the potassium level, mild hyperkalemia, and there was down titration of the molecules, the RASIs. And this is the slide, increased risk with RASI discontinuation, it's 55% risk, and 51% increased risk with RASI down titration. So even you down titrate the RASI, there is an increased risk of the events. And you can see from this nice chart, this is a Kaplan-Meier chart, and you can see from this one that patients still at risk at follow-up date when it is discontinued. In the violet you can see, and it's significant. Now, reinitiation of RASI is rare. When you discontinue, we are always not that aggressive. Like in this patient, I have added Localma, and I have been trying to add some little of RASI so that we can build up the dose. Let us see what happens in this patient because his kidney function is deteriorating. His LVEF is 25 to 30%, and he has been maintaining for the last 25 years with this ejection fraction. And patients with CKD and heart failure on AC, you see there are some numbers, 6,700 patients, 26% discontinued. I think sometimes more than this number of patients we have to discontinue, 30 to 35%, because the potassium goes to a high, is very dangerous to continue with the molecule. ARB 25% and MRA, it is the highest. About 1/3 of the patients had to discontinue the therapy and only 10% reinstituted. So what the guidelines tell? So So this is the guidelines emphasize optimizing RASI for cardiorenal patients, and RASI are recommended to reduce risk of CKD, progression, kidney failure, CV events, and CV death. So these are very beneficial cardioprotective, renoprotective molecules. ACI also reduced risk of all-cause death. ACI or ARB, now we have RNA, should be titrated to the highest approved dose that is tolerated, not in CKD patients, of course, in HEP-REP patients. ACI and MRA are recommended to reduce the risk of heart failure, hospitalization, and death. RASI also improves symptoms and slow eGFR decline. ACI should be up titrated to the maximum tolerated recommended doses. Because RASI therapy increases hyperkalemia risk, guidelines state that potassium levels should be monitored closely in patients on RASI. So how frequently we should monitor the potassium? You see it after 2 or 3 days once when the patient is in the hospital, and after that after 15 days, and after that after a month. If it doesn't go up, normally it doesn't go up. Not like this patient. He has gone up after 20 years like this. This is the rare case. From 2.2, the creatinine jumped to 8 because there is some deterioration in the kidney function over the years. He is 70 years now, and I have been treating him for the 25 years, last 25 years, with a cabbage done 20 years back. So that is not the usual story. So I will be again starting this RASI therapy on this patient with a low dose with the help of low karma. Therefore, the British people were telling in their seminar, where I was invited as a guest speaker last year, and they were telling that why not telling this SCZ as a fifth foundation therapy. Because in these 35 or 40% of the patients where we cannot give this RASI, we can give RASI in an adequate dosage with this SCZ. And after the patient improves, the necessity of giving this molecule comes down, because after a year or after 10 or 11 months, you don't have to continue this molecule. And it is very well suited, not like the other K-bonds. And this, the KDIGO guideline supports use of potassium binder over ACI ARB decrease or discontinuation for the management of ACE-ARB associated hyperkalemia. KDIGO guidelines support the use of potassium binders over AC or ARB decrease or total discontinuation. The 24 guidelines tells that CKFG affirms that for patients with hyperkalemia, newer potassium binders may help facilitate essential use of RASI MRA. We should not forget about patyromia. Sometimes it will hit our market also, because latest Brownell's book, 13th edition, has given a lot of emphasis on patyromia, and that is another drug like SCZ, which is very effective in lowering potassium. But experience is more with this molecule in Europe. Whole of Europe and UK, they use this molecule, but it's not FDA approved, so we can't tell the situation in US. It is experimental at this country, US. Potassium binders should be considered before reducing RASI, and RASI discontinuation should be the last resort to us. Now, ESC guidelines also support use of potassium binders when in patients with chronic or recurrent hyperkalemia or RASI therapy can be approved. Potassium lowering agents may be initiated as soon as potassium levels are confirmed as 5 or more. So 5 is the marker. If it is more than 5, we can start it. In a low dose, of course, suppose 5 grams you give. Administration of the potassium lowering agents, sodium zirconium cyclosilicate or patyromere, may allow RASI initiation or up titration in a larger proportion of patients. Now, this is the molecule. It exchanges hydrogen and sodium for potassium inside the intestine, and highly selective for potassium. Binding with site width and potassium ionic diameter are similar. It's insoluble, highly stable, and doses not expand in water, not systematically absorbed. So that's another advantage of this molecule. And you can see that it works in small intestine. It, based on in vitro data, SZC may begin working immediately in the small intestine to preferentially capture potassium. And we found that the first potassium sent after 2 hours in ABG came down significantly, almost by 0.5 milliequivalent. Potassium is exchanged with hydrogen and sodium. And this is the harmonized trial. We had some of the trials, not very large trial. I think they need large randomized trial to see the different issues, how safe they are. This is a phase 3 multi-center 2-phase prospective study, and in patients with serum potassium more than 5.1 at 45 nephrology and cardiology general research sites in US, South Africa and Australia, and 48-hour correction was given, open label phase, 28-day maintenance was given, and you can find it was given in a dose of 10 grams TID. For each 5 grams, you have to give 35 ml of water. So in CKD patients, you have to be very careful regarding the total fluid intake. So these are the small number of patients, and you can find that titrated in 10 grams dosage and 11th month maintenance. As I told you, you don't have to give it for 4, 5, 6, 7 years. You can complete the course in 11 months or 10 months, and then you can stop the therapy because the patient has improved substantially, and then you can stop it. So this is, I think, a significant marker because, you know, this is a problem which we face day in, day out, hyperkalemia. And believe me, we have to stop it because you can't give K-bind for a long time. These resins cannot be given for a long time. So we were looking for a molecule, and in Europe, you won't believe this was available for the last 5, 6 years. In UK also it is available for the last 5, 6 years, and they have got a huge, huge experience with this molecule, and they are telling that this molecule is very safe. And this is the harmonized correction phase. You can see that potassium decreased over 48 hours significantly to the normal level, and you can see that at 24 hours, the decrease was 1 milliequivalent, as I told you, and it was statistically highly significant. And median time to potassium normalization was 2.2 hours because it comes down sharply in the first 3 or 4 hours. And patients achieving normokalemia, you can see 84% of patients by 24 hours and 98% of patients by 48 hours. An absolute percentage is 66% of patients by 24 hours and 88% by 48 hours. So these are the primary endpoint of the trial. You can see SG said 5 gram, 10 grams and 15 grams dosage, and the potassium came down significantly from the high level. And extension means serum potassium levels across correction, maintenance and extension phases, and almost 90% of the patient receiving SGC maintain an average serum potassium of less than 5.1. So our concern is satisfied. We are damn happy with this, and initially we start with 30 to 35 grams first 2 days, and then we come down to 5 grams BID, and if the patient is okay, because we don't know what is the situation with us Indians. Why? Because, you know, with statins, the dose of statin, if you give dose of statin 10 in Caucasians, but it comes down in Indians, it comes down by 1.6 to 2.3 times more. Sometimes you find that we give atorvastatin 10 milligram, and the cholesterol has come down from 160 to 80 or 90. Though it happens not very frequently, but it does happen, and we see it. So how it behaves in Indians, maybe that 5 grams is sufficient. As I see, Devmallo is nodding in affirmative because we do, respond to the drugs in a much better way than the Caucasians or the Americans. So that is the difference. And would this molecule help to reduce hyperkalemia in heart failure patients who are on ARNI and MRS? Yes, it does. And this is a very interesting study, realized study. So I was talking to Dr. James Fang, who is the outgoing president of American College of Cardiology, in a leadership meeting last year in Delhi, and all their pioneers came. So James was telling me that we have not given approval to this molecule till now, according to the FDA documentation, because of this small study, realized potassium study, where you will find at the end of study, you see they included patients with hyperkalemia and eGFR more than 30 mils, and SGC on day 1 and initial uptitrate with spironolactone after normokalemia. The numbers were very small, 366 as you can see. But from this realized study, what they found, that in about 6% of the patient, there was edema. So edema is a marker for heart failure. And the concern was there that 6% of the patient, I know that this gentleman of AstraZeneca will not be happy with such comments on the molecule, but we have to tell you the facts because I have not come as an AstraZeneca person. I am a simple cardiologist and doctor, and I have to reveal the facts. So 6% of the patients in this realized study had edema. And you know, the EMPA outcome study, which was the first one, I remember I was chairing a session in Lisbon Hall in ESC in 2017, and I asked the gentleman who was the PI and was the steering committee chairman, he was from the Karolinska Institute, that why you didn't have these echo parameters in all the patients, neither ECG in all the patients. So he told, because there is no cardiologist in the steering committee. So now they include a cardiologist in the steering committee. So this realized study, being a hyperkalemia molecule used against hyperkalemia, saw there is a 6% elevation of edema. The patient had no edema. After using this molecule for about a month or so, they had edema. So they interpreted that the amount of the sodium in the salt, sodium zirconium cyclosilicate, might have been instrumental in causing hypernatremia and causing precipitation of heart failure in 6% of patients. But this was just a query. This was just a query because this is a very small study. It has been questioned by the European counterpart because they have used it right and left in their population, including UK, and they are very happy with the molecule and they use it. So seeing is believing. They have used in lakhs. And the number of patients in this study you can see is 366, though it was a placebo-controlled, double-blind, randomized trial, international trial that evaluated SGC for hyperkalemia and optimized and maintained MRA over 6 months in adult patients with HEP-REP not on dialysis. So this is the optimized MRA therapy, and you can see the results were very good so far. Potassium reduction was concerned. You can see fascinating 49% relative risk reduction in the time to first hyperkalemia episode with SGHC, and the hazard ratio was as low as 0.51, which becomes highly statistically significant, p-value being less than 0.301. Now, SGHC helped to delay time to MRA reduction, because MRAs are more dangerous. You saw the 33% elevation was by MRA and 26% by the other RASI, that is ACEI/ARNI/ARB. And there was 63% relative risk reduction in the time to first instance of spironolactone dose decrease or discontinuation due to hyperkalemia with SGHC versus placebo. You can see the hazard ratio becomes 0.37. And does the RCT data translate into real-world evidence? They are telling, James Pang and group are telling American College of Heart Failure, no, it doesn't suit us because there was 6% incidence of edema. So we have to see the molecule, how it behaves in our population. We should be critical about the population. 83% of the patients continued RAS use following SGHC initiation. So not 100%, but still with this molecule, we could continue this molecule in about 83% of the patient, and that included stage 3 to 5 CKD, stage 5 CKD, diabetes and CKD, heart failure patients, HEP-REP, HEP-PEF, because you know, Dr. Pfeffer told in 2014 with his TopCat study that spironolactone is the drug of choice of heart failure, and it reduces mortality by 15%, which was proved to be not true in subsequent trials. And mean duration of follow-up was 245 days, and during follow-up, mean duration of RASI and SGHC was 210 and 80 days. And you can see that rates of hyperkalemia-related inpatient admissions also were reduced significantly by 40%. And hyperkalemia-related hospitalization or ED visits does not necessarily imply hyperkalemia as the primary reason for hospitalization in ED visits. Now, they were very well-treated patients. You can see all the 4 pillars, as Shubhra was telling, and these were the drugs given, very small number of patients, as I told you. You can see that MRA is 93%. That indicates very well-treated group of drugs. And this is hypokalemia, few adverse events, edema-related events, as I was telling, just I would like to take your attention to this fact, 6% of patients receiving SZC reported edema-related events. And just to tell you that in EMPA outcome, edema was the marker for diagnosing heart failure in majority of the cases, not NT-proBNP, neither echo, nor other parameters for the diagnosis of heart failure. So incidence of hypokalemia resolved with dose adjustment or discontinuation of SZC. Minimal drug-to-drug interaction. They, of course, have some reaction with anti-HIV, antifungals. Then the thing is that either you give with these drugs 2 hours before or 2 hours after you give this molecule. So nothing much you can give with these molecules, but don't give immediately along with this. And these are the dosing patterns. Already I have told about it. And with 45 ml of water, as I told, you can go up to 35 to 45. If there is severe restriction, you can, and the dose is initially 30 to 35 grams per day, first 2 days, and then you come back to 10 grams per day or 15 grams per day. May be taken with many other medications, barring all those which you have seen, and no special conditions for storage. So to choose Lucalma to treat hyperkalemia, hyperkalemia is often recurrent and an ongoing threat, which has been associated with an increased risk of mortality and hospitalization in cardiorenal patients. For rapid potassium reduction and to sustain potassium control, use Localma managing hyperkalemia can enable guideline recommended RASI therapy. Majority of patients who are treated with SZC for hyperkalemia were able to continue this molecule. Their RASI therapy was well suited, well tolerated. SZC will continue to deliver data on hyperkalemia management and its benefits in all population in cardiorenal patients from other evidences also like crystallized program. So thank you very much, ladies and gentlemen, for your patient hearing.
Thank you, sir, for an excellent elaboration of a very new molecule. So, at least in our country. So, where would you think this molecule is indicated for in our day-to-day practice, and what would be the contraindication?
Okay, very nice question. So, what I told during the last 30 minutes or so, that in treating the patients with HEP-REP and also HEP-PEP and also HEP-MEF and also heart failure with improved ejection fraction, we always need RASI. And now how we treat these patients, if there is hyperkalemia, either we stop the molecules or mainly MRA and oblique ACI or ARB. And then we can down titrate the dose. So these are the two ways, but as I showed, both are harmful. 55% increase in event rate in case of discontinuation, 51% in case of down titrating the dose of the molecule. So now we have a molecule, and as we go by the experiences, our European and UK counterpart, they are telling that the molecule is very good. But as you know, across the Atlantic, there is difference of opinion. And James Pang, who is also a very respected person in personal communication, he told this, and about 1.5 year back, that no, this molecule causes, we have some concern. Therefore, FDA has not given approval to it as yet, because there is 6%, means 5.7% incidence of edema. But in these CKD patients, stage 3, 4, 5, severe HEP-REP patient, they can have some edema due to different causes. Suppose we are giving some amlodipine, the patient can have a edema. So this was not interpolated with NT-proBNP with the echo findings of HEP-REP, HEP-PEF, and other parameters. So this has to be taken with a pinch of salt, but just it's important to remember it while practicing. So these are the indications that always we have to give these molecules. You also give for your diabetic kidney patients. That was the indication with MSRNA, MSMRA. And you know, we also give these molecules in HEP-REP and all sorts of patients, like finerenone. Latest literature shows that finerenone is also very good for the HEP-REP patients also, but it is not in the guideline, but already it is in the guideline with HEP-PEP patient. So we have to give this gentleman, ladies and gentlemen, we have to give this molecule every day to every alternate patient, because a lot of patients have heart failure which are not diagnosed also. We are finding lots and lots of patients coming as asthma or something like that, but actually this is because of heart failure.
Any questions? We can take a couple of questions.
So it seems that there is no confusion, at least on stage and is beyond the stage. They all seem to agree either they have understood fully or they have understood nothing. So
They have understood
to
fully.
do the honors for this session,
Thank
may
you,
I
sir.
request
Thank you.